and a very warm welcome to the next edition of the series of monthly webinars. This is the second part of this series that we are doing. In the first series that we did, we had some wonderful topics. So this time we thought we'll focus on an aspect of echocardiography, which is not given as much importance as it should. Most of the times in the minds of physicians and many cardiologists also, if you do not see anything wrong with the valves or chambers, if systolic functions are all right, it is assumed that the echo is normal. But it is not so. Diastolic functions are extremely important, and we must remember that every systolic dysfunction starts with a diastolic dysfunction. And there's a wealth of information which one can glean by analyzing these functions in an appropriate way. To address these issues, we have a wonderful panel today, some of the top experts from our country, and we are fortunate to be hosting Dr. Lisa Thomas from Australia. I would especially like to thank Dr. Shantanu Sen-Gupta for organizing and taking the lead of this webinar. So over to you, Shantanu, for introducing Lisa and for conducting the seminar. Thank you.
Thank you so much, Dr. Chopra. It's indeed a pleasure to have everyone over here for this interesting webinar. And extremely thankful to the Heart Failure Association for this opportunity. So Professor Lisa Thomas is a conjoined professor at Sydney University and in University of South Wales, and is a clinical lead for non-invasive cardiac imaging at Westmead Hospital. Her focus on research has been includes left atrial dynamics and function, diastolic function, chemotherapy-induced cardiomyopathy, amyloid and Fabry's cardiomyopathies, and cardiac involvement in chronic kidney disease. She's a cardiovascular coordinator for NSW Fabry's and amyloid group. She has been actively involved for the undergraduate and postgraduate medical student and sonographer education in Australia and now all over the world. She supervises several PhD and master's students in Australia and has been invited numerous national and international meetings and has been involved in a lot of peer-reviewed journals, more than 125 papers to say. We're extremely fortunate to have Lisa Thomas. She's live with us. She's in Adelaide at present, and it is quite late, but I'm extremely thankful to Lisa for joining us. And if I can request our chairpersons to initiate her talk, Dr. Hari Krishnan, Dr. Abraham Oman, and Dr. Sanjay Mittal. Over to you, chairpersons, please.
Thank you, Dr. Shantanu. Without much delay, we will directly go to the talk. I invite Dr. Lisa Thomas to deliver her talk. Over to you, Dr. Lisa.
Thank you very much. I'd like to particularly thank Dr. Sen-Gupta and also the Heart Failure Association of India for giving me the opportunity to present today. What I'm going to talk about is the echocardiographic evaluation of left ventricular filling pressure, current concepts, and as was mentioned in the introduction, diastolic function assessment is really something that we don't perhaps do as often as we should, but which really has a wealth of information that can be utilized, particularly in patients with heart failure. So when we think of phases of left ventricular diastole, and this is when we're using invasive pressure measurements, we have minimal left ventricular pressure, a phase of rapid left ventricular filling. We then get the pre-A pressure, which corresponds to mean left atrial pressure, and A rise, which corresponds to active atrial contraction, and finally end diastolic pressure. Often when left ventricular filling pressure increases, what we first see is an elevation in left ventricular end diastolic pressure. As such, left ventricular filling pressure can be measured directly from left heart catheterization, but it also corresponds closely to pulmonary capillary wedge pressure, which we can ascertain from right heart caths. So why is left ventricular filling pressure important? So heart failure is considered now a major public health problem, and it comprises almost 1 million hospitalizations annually in the United States. Heart failure symptoms, however, are often non-specific, and it's difficult to differentiate heart failure from non-cardiac causes of dyspnea. What's also apparent now is that almost half of heart failure patients have preserved left ventricular ejection fraction. And in this group, it's really diastolic abnormality which drives the heart failure. So why is left ventricular filling pressure important? So it's important to make that diagnosis of heart failure, particularly in those with preserved ejection fraction, and elevation of filling pressures is its hallmark. It represents a compensatory mechanism whereby cardiac output is maintained. It also determines the severity of heart failure, and we can also use it to measure the response to therapy. So when we think of diastolic dysfunction, this is closely linked to left ventricular filling pressure. So you can have early diastolic dysfunction with preserved filling pressures. When measured directly using left heart caths, elevated left ventricular filling pressure is considered to be greater than 16 millimeters of mercury. It can also be measured indirectly using right heart caths and measuring pulmonary capillary wedge pressure, which corresponds to mean left atrial pressure, and the normal value is taken to be 12 millimeters of mercury. As I mentioned earlier, the end diastolic pressure may be the only pressure elevated early on in diastolic dysfunction, but over a period of time, not just the EDP, but the mean left atrial pressure, as well as pulmonary capillary wedge pressure increases. A very important concept is that in healthy subjects, the left ventricular filling pressure changes minimally with exercise, and hence we can use exercise to evaluate for elevations in left ventricular filling pressure as an indication of diastolic dysfunction, and this will be dealt with in detail by Dr. Sengupta. Importantly, natriuretic peptide levels, which correspond to myocardial stretch, also correlate with elevated left ventricular filling pressures. So briefly, we know that in 2009 was the first diastolic guidelines using echo, and this predominantly used transmitral flow. And we know that there was problems differentiating between normal and pseudonormal filling patterns. We then had the development of annular E prime velocity using tissue Doppler imaging. I won't go through some of the technicalities, but it is Doppler dependent, and we need to align the ultrasound beam to the direction of the mitral annulus, so we get an accurate E prime velocity. The ASC guidelines recommend using an average of the septal and lateral E prime velocities. And in general, if your septal E prime velocity exceeds 8 centimeters per second, you can exclude diastolic dysfunction in most instances. What we have to keep in mind, though, is that there is an age-related change in E prime velocity being much higher in younger individuals. Here's just a schematic of some of the traditional measurements on echocardiography, and the vast majority of them had a U-shaped relationship with diastolic function, as in they were similar when they were normal, as well as when it was severe. E prime, however, demonstrated a linear correlation, and as diastolic function decreased, E prime velocity decreased. Early on, we thought that filling pressure was represented by the ratio of E over E prime. So when we think of the peak E velocity, it really represents pressure difference between the left atrium and left ventricle, and therefore if left atrial pressures are high, you get an increased peak E velocity. The E prime reflects left ventricular relaxation and therefore should be decreased when you've got diastolic dysfunction with elevation in filling pressure. So this is early work by Sharif Nagwe showing good correlation with pulmonary capillary wedge pressure, and work from Ullman and colleagues at the Mayo Clinic suggested that a septal E over E prime less than 8 correlated with normal mean left ventricular diastolic pressure, and when it exceeded 15, it tended to be elevated. However, there was a big area in the gray zone. Now, bear in mind that E over E prime cannot be accurately evaluated when you've got severe mitral annular calcification, significant mitral valve disease, or a prosthetic valve, and also in conditions where there's pacing or left bundle branch block. It also doesn't do very well when left ventricular ejection fraction is preserved. So in 2016, we had the new diastolic function guidelines. It was a 2-step process, and it was really put out on the basis of expert consensus. So the first stage was to consider 4 parameters: the E over E prime velocity, peak TR velocity, and left atrial volume index, to establish whether the diastolic function was normal or whether there was diastolic dysfunction. There, however, was the likelihood of having intermediate diastolic function if only 2 out of the 4 parameters were positive. So once you established if there was diastolic dysfunction, you then move to a second flow chart to determine if left atrial pressure was elevated. So once again, the expert group tried to identify patients who would have normal left atrial pressure. So you had a E to A ratio less than 0.8 and a peak E velocity, which was low, less than 0.5 meters per second, left atrial pressure being normal. If you had a high E over A ratio, you were likely to have elevated left atrial pressure. And then in this group, we used 3 parameters, and based on the number of parameters that were positive or negative, we decide if LA pressure is increased. And once again, you see in the middle here, a group which are categorized as indeterminate. Now, once these guidelines were put out, the EACBI formulated the Eurofilling study. It was a multi-center trial where they said, look, there's an expert consensus document. We really want to see whether that lines up when we actually invasively measure pressure. And they did this in about 160 patients, comparing invasively obtained left ventricular filling pressure to echocardiographic metrics. Now, when they looked at the 4 components of diastolic function assessment, each individual parameter showed only a modest correlation. In the group with normal filling pressure, 65% of cases, the echocardiographic assessment was able to identify accurately, and similarly, in 79% of patients with elevated filling pressure, this multi-parametric model was able to accurately determine elevated filling pressures. They also showed that these correlated better to the 2016 guidelines than the existing 2009 guidelines. Almost at the same time, from across the Atlantic, there was a multi-center study from the United States, which also looked at invasive estimates. This was a bigger group of patients, almost 450 patients, who were investigated either with left heart or right heart caths, measuring LVETP or wedge pressure. Once again, you see here, individual parameters showed only a modest correlation. And if you look just at the parameter that we had previously been using, the E over E prime, its R value was modest to good at 0.65. They then used the multi-parametric echocardiographic assessment. So they used a peak CR velocity in excess of 2.8 meters per second, E over E prime greater than 14, and left atrial maximum volume greater than 34 mils per meter squared. They initially characterized these patients based on clinical assessment, the accuracy on average to identify elevated filling pressures using just clinical measures was 72%, and this increased significantly using the echocardiographic parameters to 87%. And if you combined the clinical parameters with the echocardiographic parameters, there was a net reclassification improvement of 1.5, which was significant. What I do want to highlight here is you can see that these parameters, the echocardiographic as well as clinical accuracy, seems to be increased in patients with ejection fraction less than 50%, and they're not as effective in patients who have normal ejection fraction. Now, E over E prime, as I mentioned, can be significantly affected with mitral alveolar calcification, and this can be a problem, especially in older patients with comorbidities. Now, in a group who had moderate to severe mitral alveolar calcification, the E over E prime correlation to filling pressure, as you can see here, is really at best intermediate or fair with an R value of 0.42. So what do we need to use when we've got significant MAC? And in this particular study, they demonstrated that perhaps the best use is using mitral E over A ratio. We use the same cutoff of 0.8 to decide the ones who are normal. If it's high, close to 2, they've got elevated filling pressures. And then we look at this intermediate group, and they found that use of the isovolemic relaxation time, if it's shortened in less than 80 milliseconds, was an indicator of elevated left ventricular filling pressure. And when you use these two in combination, they were able to classify 87% of patients with good specificity. Now, in that gray area where we don't know whether they have elevated or normal pressures, we can use other parameters. Here, I've shown you a Doppler trace of pulmonary vein flow. So we have systolic and diastolic forward flow and atrial reverse flow. The parameters that help us determine whether left ventricular filling pressure is increased is either the peak atrial reversal velocity, so if it exceeds 0.35 meters per second, or we measure the duration of pulmonary atrial reversal as compared to the duration of the A wave on transmitral flow, and a difference between AR duration and mitral valve A duration, if it exceeds 30 milliseconds, is again an indicator of increased left ventricular filling pressure. And this is useful even in patients with normal left ventricular ejection fraction. So why don't we use this more commonly? And the main thing is the technical difficulty in being able to get a nice crisp pulmonary vein trace, as I've shown you here. And most often we can get this only in about 70 or 80% of patients. Now, left atrial volume, as I showed you, has been included in the main criteria for establishment of diastolic dysfunction. However, recently, with the advent of strain analysis, left atrial strain is thought to be a very sensitive marker of left atrial function. This is work from Roberto Lang's group, where they used left atrial volume in a group of 90 patients, which was a derivation cohort. And what they found was that there was an overlap between grade 1 and grade 2 diastolic dysfunction if you were using just left atrial volumes to stratify the groups with diastolic dysfunction. However, if you were to use left atrial strain, you got much clearer segregation of various grades of diastolic function. And they suggested that in the group who had intermediate diastolic function using left atrial volume, they could reclassify almost 10% of these patients using left atrial reservoir strain. And I might add here that reservoir strain is what we measure in systole, and it represents left atrial filling. Similar results were shown in a large population group of almost 500 patients with varying conditions and varying grades of diastolic function. Now, in this group of 500 patients, if you looked for elevated left atrial volume greater than 34 mils per meter squared, only a third of these patients had an enlarged left atrium. But if you looked at left atrial strain using a cutoff of less than 23%, 2/3 of this group demonstrated a reduced strain. And they therefore found that they were able to improve the detection of diastolic function from 13% to 23%, and that a low left atrial strain was associated with adverse outcomes, including having a worse NYHA class and a higher risk of heart failure hospitalization. So this was a review paper that I was involved with, and we felt that the role of left atrial strain is perhaps in the early stages of diastolic function assessment. So you see a reduction in left atrial strain very early in the transition from a patient with normal diastolic function to significant or easy to diagnose diastolic function, and that it actually precedes or occurs earlier than an enlargement in left atrial volume. Based on this, the group of Roberto Lang wanted to again look and see whether left atrial strain could help to diagnose elevated left ventricular filling pressures. And their hypothesis was, can a single measurement actually replace the multi-parametric measurements that we have been using since the 2016 guidelines? So they used a small cohort of 26 patients to derive a cutoff value for left atrial strain, and the cutoff value of reservoir strain was 20%. As you can see, here is an example of a patient who has normal index volume, a low E over E prime, TR velocity, which is almost not measurable, and an E over A ratio, which is low. The pre-A EDP measurement was normal, and a left atrial strain was high at 41%. This is in contrast to a patient who has a high E over A ratio, elevated E over E prime, enlarged left atrial volume, elevated EDP, and a corresponding left atrial strain, which is reduced. They also found that by using left atrial strain in situations where guideline-based evaluation was not possible because you were unable to obtain one of the measurements, left atrial strain could be included. On the basis of these early findings, a multi-center study was developed by the group in Norway. So the first thing they wanted to do was to establish determinants of left atrial strain. And in addition to the reservoir strain, which occurs in systole, they also elected to look at left atrial pump strain, which actually corresponds to active atrial contraction. What they demonstrated was that both reservoir and pump strain are dependent on left ventricular filling pressure, on left ventricular global longitudinal strain, because there is, we know that when the annulus descends during systole, that's what helps with left atrial filling. And finally, that the geometric left atrial volume would also alter left atrial strains. So in this group, they once again invasively measured wedge pressure or end diastolic pressure, and half of this group had elevated invasively determined left ventricular end diastolic pressure. When they used left atrial pump strain or reservoir strain as a single measurement, the area under the curve using ROC analysis was moderate, with an AUC of 0.76 and 0.77. So for both strains, elevated left ventricular filling pressure, as you can see, 85% accuracy, 81% accuracy was more, once again, in a group with ejection fraction less than 50%. Though if you look at accuracy in the total group, it was to the order of 70%. They then tried to determine a cutoff for left atrial reservoir strain, and the cutoff that they used was 18%. And when individuals demonstrated left atrial strain less than 18%, or a pump strain which was less than 8%, it best predicted elevated left ventricular filling pressure. Strain measurements did better than left atrial volume and conventional Doppler parameters. When they used the diastolic function guidelines to evaluate left ventricular filling pressure, they were able to identify this in 83%, and this was similar to if they used left atrial strain on its own. However, the benefit of using left atrial strain was that the feasibility improved. So in almost 10% of patients, you had one or the other echocardiographic parameter that you could not use. And if you substituted left atrial strain, feasibility improved to 99%. Also, a high strain, so a pump strain greater than 14%, or a reservoir strain greater than 24%, were good to identify patients with normal left ventricular filling pressure. So in the most recent 2022 ESC expert consensus document for evaluation of patients with HFpEF, the diagnostic algorithm has altered compared to what was initially proposed. So once again, we see that if the E2A is low and E velocity is low, it's very easy. We would think that they have early diastolic dysfunction with normal filling pressure. If E2A ratio is high, that again tends to be something that's very accurate in evaluating patients with elevated filling pressures. We then, in the indeterminate or the intermediate group, apply either the E over E prime, the TR velocity, or left atrial volume, and it's then decided whether 2 out of 3 criteria are positive when left atrial pressure is elevated, or if they're negative when they've got normal left atrial pressure. However, in the current guidelines, they've introduced the use of left atrial reservoir strain of 18%, and that this can be used to replace any of these missing parameters. There are caveats, however, that it has limited utility in AF, left bundle branch block, or pacing. So the clinical utility of left atrial parameters, left atrial maximum volume, we're all aware of, and it represents the chronicity of diastolic function. What's now becoming more important is that left atrial minimum volume, which is in end diastole, may be a more sensitive measure. Certainly, evaluation of left atrial function using reservoir pump strain has been demonstrated to be of utility in classification as well as identification of diastolic function, and to evaluate association of elevated left ventricular filling pressure, particularly in patients with HFpEF. So in summary, heart failure is increasing in prevalence, especially HFpEF. And in these instances, it's not just systolic function that we should evaluate, as was mentioned by the chairperson. Invasive measurements are certainly the gold standard. They're not always feasible and certainly not practical for serial measurements. Echocardiography remains the commonest non-invasive screening test and something that's not very expensive and widely available. Diastolic function assessment as well as estimation of left ventricular filling pressure is complex. It cannot be defined by a single parameter. And we can't just use parameters derived from a test. We always need to evaluate a patient comprehensively, adding on clinical characteristics as well as associated comorbidities like hypertension, diabetes, etc. Echocardiography, as I've highlighted, can help in a large number of these cases, especially if we were to combine it with clinical characteristics. And with that, I'd like to thank you for your attention.
Thank you, Dr. Lisa. It was wonderful hearing from you about all the knowledge about the left ventricular filling pressures. You very rightly said there is a concern with all of us cardiologists to understand the difference between diastolic function, diastolic dysfunction, and diastolic failure. It is the failure part which actually is something very important for the prognosis, as well as the simulation with the symptomatic status of the patient, whether the person is having systolic dysfunction or diastolic dysfunction. The symptoms correlate more with the left ventricular filling pressure, and that is why it's very important to understand and assess diastolic filling pressures for all practical purposes. I think we'll keep the questions to the last, and after we have heard the other talks. Dr. Hari?
Or we have the questions now?
I think let's have the questions for Dr. Lisa now.
Okay.
So can I go ahead, Dr. Chopra?
Yeah, please go ahead.
Yeah, Dr. Lisa, thank you very much. This is specifically regarding post-mitra clips. What we see, we do a lot of mitra clips, and what we see is the LA volume comes down, the regurgitation practically disappears, but the E by E prime remains high. And we would like to keep the patient dry, because otherwise the clips may give way, and it's very expensive here in India. People have to pay through their pocket. So the questions are like how indicative is E by E prime post mitra clip in patients with secondary MR? That is one. And also in patients who had, most of these patients have had MIs, multiple angioplasties or bypass surgeries, especially anteroval septal MIs. How accurate is E by E prime? And again, about LA strain, can you just elucidate more about different kinds of LA strain, reservoir strain, conduit strain, and the contractile strain? Because sometimes we have to pay patients' BP is low or borderline. We would like to give more diuretics. E by E prime remain elevated, but how fast the strain, LA strain, comes down after a mitra clip? So these are my questions.
Thank you very much, Dr. Ullman, for those questions. So I just address them one by one. The first question was about the use of E over E prime with mitral clip. So we know that mitral clip actually, in a sense, is creating a degree of functional mitral stenosis. So it's a little bit like having increased mitral annular calcification and functional mitral stenosis or a prosthetic mitral valve. I don't have actual, I'm not sure of any studies that have specifically looked at correlations of left atrial strain and mitral clip or of E over E prime, but I certainly think that E over E prime may not necessarily reflect accurately the filling pressure like in someone who has a normal mitral valve. Your second question was, what about patients who've had prior infarcts and how would the E over E prime be affected? So if you have localized regional wall motion abnormality, the E prime velocity can be significantly reduced. So this is why they've moved towards using an average of septal and lateral E prime velocity. However, if you find that, you know, the septal left ventricular segment, which is adjacent to the annulus, is akinetic, it may be better to just use the lateral E over E prime instead of using the average, because certainly if there's wall motion abnormality, your E prime is going to be lower, and then your E over E prime will be increased. Your final question was about left atrial strain. In the interest of time, I didn't show what a typical left atrial strain curve is. Typically, what's measured and what's easy to do is to measure left atrial reservoir strain, because that's peak strain during left ventricular systole. This seems to be a marker of left atrial compliance. And the thinking is that when left ventricular filling pressure is increased, this gets transmitted to the left atrium, causing it to enlarge and also get stiff. In diastole, we have conduit strain, and subsequently at the end of diastole with active atrial contraction, we see a decrease in left atrial strain, and this is a measure of pump function. The actual strain curves depend on how you gate it. So if there's R2R gating, you get positive conduit and positive pump strain, whereas if you use P2P gating, you get a negative initial contractile strain and then the positive reservoir strain. So in terms of ease of function, and the body of literature to date has predominantly focused on reservoir function as opposed to pump function. We can also measure reservoir strain in atrial fibrillation, but we cannot measure the pump function because there is no active atrial contraction during atrial fibrillation. So I hope that's addressed some of the issues.
Dr. Lisa, there have been a couple of questions in the chat box also. There's a question that there is a respiratory variation in the E to A ratios. What is your take home for the people who have been using this thing? How to be cautious about it?
So that's very correct. And usually the guidelines have always mentioned that these measurements should be done in end expiration. So ask the patient to expire and then take your measurement. And that way you're consistently measuring it at a particular phase with respiration.
And there is another question, and always an Achilles heel is atrial fibrillation. How do we assess end diastolic pressure in atrial fibrillation?
So I had put a little subtext in one of at the bottom of one of the slides. There is a suggestion that, so the first thing with atrial fibrillation, we need to do multiple measurements. So it's an average of 3 to 5, keeping in mind that the RR interval is roughly the same. The suggestion is that you use E over E prime ratio of 11. In the particular paper I showed you, which looked at the 322 patients, about 43 of them had atrial fibrillation, and they still use the same left atrial reservoir strain cutoff of 18% to identify patients who had elevated filling pressures. But as someone who measures left atrial strain often, measuring it in atrial fibrillation can be quite challenging.
Dr. Thomas, if I can ask a question, we focus a lot on diagnostic criteria for diastolic dysfunction, but once we have treated the patient, do these parameters start to normalize? Because we focused on the diagnosis, but are these parameters going to normalize, if any?
So this again is a great question. And the Doppler parameters, so E to A, E over E prime TR, they're very connected to loading. So they represent more the acute state of the patient. For instance, if you've got a patient before dialysis, E to A ratio may be close to 2, but you dialyze them and get rid of fluid and they suddenly go back to impaired relaxation. So you see that acute fluid shifts can affect your transmitral, the Doppler parameters. Left atrial volume is considered a more chronic marker, something that represents elevated pressures over a period of time rather than just acute relationship. However, if the atrium has remodeled beyond a point, you may not see a reduction in left atrial size, and you often don't see a reduction in left atrial size in atrial fibrillation patients. However, in AF patients, if you actually diurese them and manage their filling pressures, you can see an increment in left atrial strain. I do want to say that while these parameters are very helpful, you will still have a group of patients where you get conflicting results. And just at today's meeting, there was a very interesting case showing just mild to moderate mitral regurgitation in a patient who had severe dyspnea. But this patient actually had amyloid and had a stiff left atrium, so no change in the atrium. So in those instances, even small volume loads with mitral regurgitation can actually make a patient decompensate. And in some instances like this, the use of exercise to determine what happens is extremely useful. And I'm sure that Dr. Sengupta will cover that.
One more small question. The cutoff for the LA and the wedge pressures is 12. Whereas for the LV filling pressure, we use a cutoff of 17. So why do we use different filling pressures? I know that is what the data shows, but why is there such a discrepancy in the data?
Yes, so I think the wedge pressure is a reflection of left atrial mean pressure. And that's why we use the 12. Whereas the LV pressure is actually a direct measurement of left ventricular end diastolic pressure. And that's in some ways correlates to the diagram that I showed up front. So your pre-A pressure corresponds to the wedge pressure. So if you're measuring pre-A in LV diastolic pressure, then it's 12. Whereas if we're looking at mean diastolic pressure, it's 16.
Okay.
So, Dr. Lisa, a couple of things which I just wanted to ask you. One is you did say about the E to E prime ratio as well as EA ratio changing with volume loading situations. What and how soon do we find the change in LA volumes and LA strain after a proper decongestive therapy or a heart failure therapy?
So with LA volumes, it tends to be quite slow. You don't often see a change sort of acutely. It's not something you often see in days, it's more in weeks. Whereas left atrial strain, you can see a change really in days rather than weeks. And with the Doppler parameters, it's almost like you diurese the patient and you do the transmitral flow, and it can be, once they've diuresed 2 liters and you've decongested them, you can see a shift from pseudonormal to in-bed relaxation. So you see it much sooner, really.
Yeah, so there is a question again by Dr. Shanmugh Sundaram. He says that reproducibility of LA strain versus LA volume. We find that the LA volume is less reproducible as compared to LA strain. What is your opinion about it?
So one thing that 3D echocardiography has taught us is that how we measure the left atrial volume is really crucial. So when you've got a normal size heart and normal function, you can use the standard apical 4-chamber and 2-chamber view. But when we've got a dilated left atrium, we actually need to optimize the left atrium. So you need to be sort of a bit off axis. So you're not focusing on the left ventricle, but you've got to measure the left atrial volume as being optimized in both the 4 and the 2-chamber view. And if you check your left atrial length, it should be roughly the same in both the 4 and the 2-chamber view. Whereas if it's not optimized each time, left atrial volume measurements can show discrepancy. Also, with the advent of 3D echocardiography, certainly these volumetric measurements are much more reproducible.
Thank you, Dr. Lisa. I think in the interest of time, we have to move on.
Thank you.
We wish that we could have talked to you forever. But Shantanu, I think if you can introduce the next set of speakers.
I'm next. So,
Shantanu is the next speaker.
Oh, Shantanu is the next speaker.
So I will share my slides.
Dr. Shastri, Dr. Yadav, and Dr. Venugopal will be chairing this session. I see Dr. Shastri and Dr. Venugopal and Dr. Rakesh here.
I think we have already heard about Dr. Lisa talking about the role of exercise and the alterations in the diastolic parameters. I think without wasting time, let me now invite Dr. Shantanu Sengupta to talk on exercise and diastole. It's going to be one of the most talked about topics in the future in echocardiography. May I invite Dr. Shantanu Sengupta to give his talk?
Thank you, Dr. Venugopal. I hope my slides are visible.
Yes.
So, so I think this was an extensive and very good description from Dr. Lisa. But I'm going to add on to that with looking at the importance of exercise. So this was the paper which came in 2008, which showed that whenever a person is getting admitted with a heart failure event, he or she will always have some evidence of hemodynamic condition 2 weeks prior. So if we can unravel this by some form, by looking at non-invasively, by doing an exercise, then I think we can prevent this heart failure related events and we can prevent admission. Now, this is what has been shown at various slides, and also Lisa showed that the algorithm for diastolic function. And there has been a focus that if you see that the patient has a normal left atrial pressure with some evidence of diastolic dysfunction, but if still the patient is symptomatic, then there is a role of stressing the patient by doing a diastolic stress test and by exercising. And it is important to understand that the spectrum of heart failure with preserved ejection fraction can have minimum involvement of myocardium, can also have maximum involvement. And the spectrum goes from infiltrative cardiomyopathy to a spectrum where the predominant problem is either in the renal or liver, or the patient has some morbid obesity, which impacts the cardiovascular system. So the exercise test can be pharmacological, you can have physiological exercise tests, Dobutamine stress test we have been doing for coronary artery disease, but now some papers have come up which has shown that you can still try to use it for unraveling the heart failure symptoms. The most common is the physiological test, and the mostly used are bicycle ergometry, treadmill tests, and passive leg rest tests. So these are mostly doable at our day-to-day practice. Now, it is very important to understand what happens with exercise in an echo in a normal subject. Systolic function increases, you have increased cardiac output. With diastolic function assessment, there can be, because of increasing heart rate, the mitral E velocity increases. There is a decrease in the mitral A velocity. The deceleration time decreases. You have parallel increase in the E by E prime also in a normal heart. So the E by E prime is almost normal with a normal filling pressure, and the mean pulmonary pressures remain predominantly normal, less than 25. This happens in a normal subject. While so the most of the time, there is an augmentation of the myocardial relaxation, which occurs in the earlier phase of diastolic function. So the LA, the A velocity doesn't change much, so the E by E prime is maintained. But with heart failure, in early heart failure changes, or in advanced heart failure, preserved ejection fraction, with exercise, the LVEDP progresses very rapidly, depending upon what stage the patient goes to us. Now, how to do a regular exercise test? You can do it by bicycle ergometry on a treadmill. So at rest, acquire all the images, 2D images, the E and A velocities, the E prime velocity, look at the TR velocity with continuous wave Doppler. You can either bicycle the patient, or the advantage is you can do a continuous echo monitoring at this stage, but the bicycle ergometry is an expensive tool in India. Very few centers have. We can also use a treadmill. We generally use a modified boost protocol. The advantage being that it gives some time for the patient to adjust on exercise, because these patients can suddenly become breathless. So you can, the only thing is, once the exercise is over, the patient can be symptomatic at the peak exercise. You ask the patient to lie on the bed and don't acquire the images immediately, because at heart rate of around 120 and above, the E and A velocities get fused. The only difference between doing exercise testing in an coronary artery disease and a heart failure patient is that it is not necessary for us to achieve the 220 minus heart rate and 85 percentile. You generally stop the exercise once the patients start becoming breathless. You only need the heart rate to go up to around 120, 130, and you can stop and try to acquire. It is a recommendation that you start acquiring the images post-exercise after 2 to 3 minutes, when the heart rate goes to around 116, 112, or anything less than 120, because the diastolic parameters of the filling pressure stay for some time after 3 to 4 minutes, even after exercise. So don't acquire the images immediately at the peak exercise, because the EA velocity are generally fused at the heart rate is whenever the heart rate is higher. Now, what is considered a treadmill or exercise test is to be positive? So if on exercise after 2 to 3 minutes, if the average in E by E prime is more than 14, or the septal E by E prime is more than 15, the PR-TR velocity increases to more than 2.5, or the septal E prime velocity is less than 7. So if all the three conditions are met, then you tell that the diastolic stress test is positive. One of the reports says that a post-exercise E by E prime of more than 30 is quite specific for a high filling pressure. And this is how we acquire at rest and at stress, and you can have a ratio of E by E prime. Now, there has been sudden interest of whether we can use a passive leg raising test. If the answer is yes. So what you do in a passive leg raising test, you can do it on bedside, is to elevate both the legs passively. Ask the patient not to do it, but maybe you can ask your staff nurse and help to raise the the legs passively and just do an alternate leg raising for roughly around 30 times. This transiently elevates the preload and it can unmask the LV filling pressure, and you can have an E by E prime of more than 14. This can be a bedside tool which can be easily been done. The biggest advantage is you don't need a treadmill, you don't need anything bicycle ergometry, and the heart rate is favorable. It doesn't go very high, keeping the EA to be separated. And this has been validated recently by this article which came just few days back in circulation, looking at the value of passive leg raising test during in diagnosing HFpEF, and they have correlated with right heart cath. So what they have seen, so these are the three groups. This is the non-HFpEF, this is the occult HFpEF, and patients who are already diagnosed to have HFpEF. And this is at rest, at passive leg raising, and at exercise. And you can see there is so significant raising of pulmonary capillary wedge pressure even at passive leg raising exercise in this group of patients. So what they have suggested is that if a patient, you can ask the patient to rest in supine. So this is a correlation with the right heart cath. So if the pulmonary capillary wedge pressure is less than 15, you can ask the patient to do a passive leg raising test. And if the wedge pressure goes more than 19, you are surely diagnosing heart failure with preserved ejection fraction. But if it still remains less than 11, then you are most likely rejecting the heart failure with preserved ejection fraction. But this is a very important paper which came up and has validated correlation with the right heart cath. So this can be done on a bedside. Remember the Sheriff Naguez paper which came way back in 1997. You can always have a bedside assessment of pulmonary capillary wedge pressure, which has a sensitivity of around 8 to 85. By this formula, it is 1.24 into E by E prime, and you can add +2. So it gives you a rough idea what is the pulmonary capillary wedge pressure on a bedside too. So this paper has validated the use of passive leg raising things. There are a few advanced parameters which you can always use in exercise, that is global strain, left atrial strain. Dr. Lisa has been focusing on left atrial strain a lot, and it is really a big tool. Remember that heart failure preserved ejection fraction is an important entity which you have to start looking at the strain, because you can have a entity of heart failure with preserved longitudinal strain where the GLS can be absolutely normal, where the problem is predominantly on the left atrium. And these are the various reasons where the role of left atrial strain has come up. Now, somebody was asking, Dr. Omen was asking, what is left atrial strain? So I thought, let me add on. I'm just trying to show you that this is a normal curve of left atrial strain. The normal values are something around 38. You have ±2, which is also called the reservoir strain or peak atrial longitudinal strain. This is nothing but the conduit strain, and you have the booster strain or the peak atrial contraction strain. Maximum studies are being done on the reservoir strain, and for reason what Dr. Thomas has been telling. And the cutoff is, the normal is around 13, because there was one question I saw. Remember, this strain parameter is being done by a type of gating, which is very important for us to remember. This is nothing but the RR gating. So whenever you are gating using the RR gating, this kind of curves you get. But there are few papers which have used the PP gating also, but you get an initial negative wave, which is the atrial contraction, and then you get a positive wave, which is basically the next wave. But most of the guidelines, most of the papers are using RR gating, and we have been using this RR gating. And the PALS or the reservoir strain is now being utilized extensively for the research purpose. So this is how we look at all the strains, looking at the left ventricular global longitudinal strain, which is mostly negative, and the left atrial strain, which is predominantly positive. And this is what Dr. Lisa had added up. I'm just going to move ahead. Now, left atrial strain is one of the key determinant of exercise capacity in HFpEF, and there are various studies which have correlated the looking at left atrial strain. That this is one of the papers which came where they looked at the response to exercise on left atrial strain, where they had around 49 HFrEF with 20 HFpEF and controls. So they said that with exercise there was limited augmentation in HFpEF, but there was hardly any augmentation in HFrEF. The reason is that with exercise in normal heart, there is a predominant suction, which predominant, but the left atrial mechanics, the push which is needed is lost, or it is reduced in patients of heart failure, both in HFpEF and HFrEF. This was Dr. Lisa's paper where we have shown, and they have very nicely looked at the exercise parameters on the E by E prime. I would like to focus on this, that in the early phase, the E by E prime may be normal, but after exercise, you can have this E by E prime which gets elevated. And they also suggested an LA strain values of less than 19. So we are still, I think the cutoff is going to be around 18, 19. We need more work about left atrial strain. But I got interested in looking at the left atrial strain and the amount of exercise, what happens to that. And this is the paper we just published last 2 weeks back. And we looked at both the role of exercise and strain, both the longitudinal strain and the left atrial strain in control, heart failure with preserved and reduced EF. And we saw that there was with exercise, the PLS went down in heart failure with preserved ejection fraction. And this is the group of patients. But the interesting part, which we could conclude in our group of patients of both HFpEF, HFrEF, and control is that the exercise time was independently associated with on multivariate with cardiac output, the MAP, the peak atrial longitudinal strain, and the end diastolic RV size. And we could see that if there is a 1% reduction in the peak atrial strain, it was associated with 10 seconds reduction in exercise time. So left atrium is a very robust marker, and it has got importance now, and you can now predict what is going to happen to a person, because if you can serially follow up these patients with exercise, or if you can train them with exercise, then you can influence the parameters. So what I would like to conclude is that diastolic dysfunction is still a puzzle in HFpEF, and we need more information. And exercise helps in understanding the pathophysiology of diastolic problem, and focus on left atrium, both at rest, both at exercise, is now emerging. Thank you so much.
Thank you, Dr. Sengupta, for an excellent talk on the role of exercise in assessing the diastolic functions. May I invite Dr. Rakesh Yadav and my co-chairs, Dr. Rakesh Yadav. You said,
I think you carry on.
Yeah, you said one interesting thing, that 2 weeks prior to a heart failure admission, which group of patients would you really look at this way? Because you said you could prevent admissions for heart failure. Would you target a select population?
Yeah, so I think the patients who are hypertensive, diabetic, hypothyroid patients, all these patients who I mean, if you ask them, do you get breathless on exercise or on climbing stairs, they come to us with the BP of 170, 90, minimal edema feet. And if you get an echo, your E by E primes at borderline, look at the left atrial strain, you can exercise them and unravel this thing, because it's all about the filling pressures. Because if you don't treat them, then I'm sure they're going to land up in some kind of heart failure related problems. You can prevent the admissions.
An excellent talk. Now, another question to you. Some of these patients are prone for arrhythmias during stress. So what happens in these individuals? How, for example, even a little bit of a ventricular ectopy or things like that.
Right. So the thing is, whenever you're exercising them, you have to be very careful. So we always use a box protocol of stopping the exercise. So you don't need to exercise them very, very much. So I suggested try to go for the modified Bruce protocol. So you start slowly. Even if their heart rate goes to around 120, 125, stop it. And then you can ask them to lie down and try to unravel the E by E primes and the other parameters. So yes, arrhythmias, mostly atrial fibrillations, ventricular ectopics can be challenging, but you have to always be careful about the exercise. Whenever you're exercising, you should have a backup of whatever you do in the coronary artery disease algorithm. So yes, the only safety I will suggest is go for a Bruce protocol and don't let them exercise so much, because they have something called, even if their heart rate goes to 110, 120, you can unravel the diastolic parameters, which is necessary for diagnosing the high filling pressures.
No, I'm not talking about the problems of the question of interpreting the data, for example, by Gemini and things like that, so this can all alter the.
Yeah, so then as Dr. Lisa was telling, if you have an atrial arrhythmias, then you have to take multiple beats. If you have ventricular arrhythmias, then I think E by E prime, whenever you have a normal beat, take that. But LA strain is always helpful in this group of patients.
Bendopnea is recently, a lot of interest has come up in bendopnea rather than exertion. Is there any correlation to diastolic function with bendopnea?
Oh my God, I'm not aware of that. I've not come across any. Dr. Lisa has any idea about that? Bentopnea and.
Because there are a lot of patients who do not give you history of exertional dyspnea, but they straight away tell you that whenever they bend down and then they get sick. Is there any correlation with this? I just, out of my curiosity,
I'm not aware of it, anything.
I think
you're muted, Dr. Lisa.
Sorry, I'm not aware of any studies that have looked at that, but certainly it's something that patients complain of a lot.
Not aware of that.
Okay, so I think let's move on to the next topic. If there's nothing else, invite Dr. Jayagopal, Dr. Sandeep Seth, Dr. Wonder, I don't see. So Sandeep and Jayagopal, please carry on.
Yeah, thank you, sir. I think we are already late, so let's not waste time. Invite straight away Dr. Mohan to give his talk on the echo in heart failure with preserved ejection fraction. Over to you, Dr. Mohan.
I think the theme is same. We are talking about heart failure with preserved ejection fraction and left ventricular filling pressure. And I would try to talk about prediction and pitfalls in estimating LV filling pressure by echo Doppler. To a great extent that has been done by Dr. Thomas, but let me take you once again through this topic. So heart failure with preserved ejection fraction is a heterogeneous clinical syndrome characterized by depressed reserve capacity involving multiple domains of cardiovascular function. Stiff left atrium, left ventricle are unable to use the Frank-Starling law to increase stroke volume. So what happens is that for a certain degree of increase in stroke volume, wedge pressure or filling pressure rises abnormally. How abnormal is the slope of rise in wedge pressure in response to cardiac output or stroke volume has been studied by multiple people, but here is a study from Mass General Hospital by Dr. Gregory Lewis looking at control individuals versus normal individuals. The control individuals shown in green dots, and of course the red boxes are individuals with HFpEF. As you would note that with increasing exercise, as the cardiac output increases from baseline 5 liters to up to 15, 16 liters, the wedge pressure rises. The rise of wedge pressure with increasing cardiac output is much steeper in HFpEF. It is nearly 3 times steeper compared to normal controls. The other way of looking at HFpEF is that, as was being discussed, that typically you would make a diagnosis of HFpEF if the filling pressure at rest is more than 15 millimeter in patients who have dyspnea, ejection fraction above 50%, and structural heart disease. Barry Borlaug's group has suggested that you can almost say that the patient has 100% sensitivity and specificity for HFpEF in case resting wedge pressure more than 15 millimeter and on peak exercise crosses 25 millimeter mercury. This is corroborated by Gregory Lewis' work, which has shown that wedge pressure rarely in normal individuals crosses 20 millimeter of mercury. However, the same work from Barry Borlaug did suggest that if you are doing invasive catheterization and wedge pressure above 15 will be present only in 56% of all clinically recognizable HFpEF. Although specificity remains high, but if you rely on a hemodynamic parameter of wedge pressure above 15, you would miss 44% of the individuals. Here comes the role of echocardiogram, because we believe that premise of echo is there are telltale signs of HFpEF present in those with non-elevated LV filling pressures. Look at the other way. Echo would improve sensitivity because there is an analogy of random blood glucose versus HbA1c. Measuring PCWP is like checking random glucose level. While doing an echocardiogram and looking at multiple parameters, which Dr. Thomas described in great detail, is like looking at HbA1c. Obviously, if you are going to use echo parameters, it is going to improve the sensitivity compared to invasive catheterization. But the point is it true? And we will look at that aspect in a while. But there isn't any doubt that single time point hemodynamic measurement may not fully capture the underlying physiology of the disease, and is true for all modalities, including echocardiogram. However, it's much more true for invasive hemodynamics. So based upon invasive hemodynamics, you would have two types of HFpEF, two phenotypes of HFpEF. HFpEF with normal resting filling pressure, which would constitute about 40% of the patient population, and HFpEF with elevated resting filling pressure, which will constitute 60% of all. And we did have a discussion about the left ventricle filling pressure. In a true sense, directly measured mean left atrial pressure or right atrial pressure in absence of inflow obstruction represents accurate filling pressure. However, for us clinicians, wedge pressure is much more meaningful because it is an indirect reflection left atrial pressure and usually would be more predictive in a patient of HFpEF compared to left ventricular and diastolic pressure. Here is an interesting study showing if you take wedge pressure above 20 or less than 20 or LVDP more than 20 and less than 20, you will realize that wedge pressure predicts event-free survival much, much better and clinically in a statistically significant manner, but not left ventricular and diastolic pressure. We also have data to suggest that survival in HFpEF patient not only is impacted by wedge pressure at rest, but also by wedge pressure on exercise. And this is important to keep in mind because both these parameters do define what we understand now as a condition called heart failure with preserved ejection fraction. We're also aware of the fact that filling pressure, which are elevated both at rest and on exercise, have hazard ratio 5 times more compared to normal controls. So the data also suggests that if you look at wedge pressure to cardiac output slope, and if the normative band of normal individuals is considered less than 2 millimeter mercury per liter increase in cardiac output, if that criteria is used, again, looking at this work from Gregory Lewis from Boston, the slope of wedge pressure to cardiac output is more than 2 millimeter of mercury per liter. then the event-free survival is much poorer compared to a slope of less than 2 millimeters of mercury. This again points out to one fact, that our definition of heart failure with preserved ejection fraction would have to be based upon a relationship of wedge pressure to cardiac output, whether at rest or an effort or combination of the two. The other point, which since we are on the issue of left ventricle filling pressure in HFpEF, we need to understand that HFpEF is a high gain system. That means with a slight increase in preload or afterload, filling pressures would rise markedly and the slope would be much steeper. The other point which we need to emphasize is that pulmonary hypertension is very common in HFpEF, and pulmonary pressure rise steeply during effort. Study by Carolyn Lamb from Mayo Clinic suggests that for a HFpEF, most of the HFpEF patients, 83% have pulmonary artery hypertension, while hypertension, a condition with diastolic dysfunction, just have only 8% individuals with pulmonary hypertension. This algorithm has been shown by Shantanu and Dr. Thomas, again to point out the one single fact that in between part, the so-called indeterminate mitral flow and indeterminate diastolic function and raised filling pressure, where you use three parameters, left ventricle volume index, E to E prime ratio, and TR velocity, still can leave you large number of patients whom you cannot decide whether to categorize these individuals with normal filling pressures or raised filling pressure, despite dichotomizing 2 out of 3 and less than 2 out of 3. And Dr. Thomas did mention about this guidelines from American Society of Echo and European Society of Cardiovascular Imaging, suggesting that you can either use 3/4 parameter as shown in the left lower quarter, or the E to E prime ratio when average is more than 14, or a septal E to E prime more than 15 is suggestive of increased left atrial pressure. Dr. Shantanu also mentioned that E to E prime less than 8 at any location would indicate normal left ventricle filling pressure. So far, it is good. But what has happened is that in practice, most of us have erroneously adopted E to E prime as the only standalone measure of filling pressure and ignored the concept of multi-parametric approach, which has been suggested by guidelines. And this unfortunate thing came out of a paper which Sharif Nage published more than 20 years back, nearly 25 years back, where he showed an excellent correlation between wedge pressure and E to E prime in individuals who had heart failure. More recently, he and his group in a multi-centric American study, as Dr. Thomas showed, did show that the relation between E to E prime and LV filling pressure in these 470 patients was very, very modest, with an R value of 0.65. Obviously, E to E prime does get in right ballpark, but it cannot always predict correct LV filling pressure. Dr. Lisa Thomas did mention about this work by Steve Omen, published about, again, 22 years back, which showed that the correlation with mean left ventricle diastolic pressure and medial E to E prime is very, very modest. Although they were able to categorize people having a mean left ventricle diastolic pressure more than 15 by a ratio E to E prime, medial by more than 15, but keep in mind that it only showed high specificity. This E to E prime medial had a modest sensitivity in diagnosing elevated left ventricle filling pressure. Dr. Thomas did mention about this study by Patrizio Lancelotti, which is called Eurofilling study of 119 patients with simultaneous cath and Doppler using parametric approach, not the E to E prime approach, but all 4 parameters, where E prime has been taken separately, E to E prime ratio has been taken, TR velocity, and LA volume more than 34 ml per meter square. If you use 3 or more parameters as criteria of elevated left ventricle filling pressure, sensitivity of these parameters is 75%, specificity 74%, and negative predictive value was found to be 93%, which one would say clinically is pretty much acceptable. However, the thing which needs to be kept in mind is that Barry Burlock, when he applied the same 3/4 formula on his patients suspected to have heart failure with preserved ejection fraction, and later on proven to have heart failure preserved ejection fraction by invasive criteria, the sensitivity of 3/4 parameters was only 34% and specificity 83%. Using ESC criteria for HFpEF, which include natriuretic peptides, which include left ventricle mass, which does include global longitudinal strain, besides the parameters we have already talked of, just marginally improved the sensitivity to 60%, although specificity came down slightly more. Looking at E to E prime as a criteria of left ventricle filling pressure, raised left ventricle filling pressure, this excellent meta-analysis by Sharifov from Birmingham showed that if you are looking at E to E prime parameters, septal, lateral, or average, sensitivity of parameters does not exceed more than, is 24 to 37%. Although, if E to E prime is more than 14, the specificity is certainly 90 to 98%, again indicating E to E prime, if elevated, certainly suggests elevated filling pressure. However, normal or less than 14 E to E prime average does not mean filling pressures are not elevated. Some recent work actually from Netherlands also showed a very poor correlation between E to E prime and pulmonary artery wedge pressure. This is just to again buttress the point that repetitively people have shown that what initially was shown by Dr. Sharif Nege in a study of 60 cases, probably in patient with heart failure, may not be true, and it may have been a single center bias study. The other parameter, the other thing which we have to keep in mind, in case we have to actually give importance to individual parameters, then the PA pressure or TR velocity probably will gain higher value compared to E to E prime, which of course is at a higher value compared to left atrial volume index. Let me just show you a couple of examples to buttress the point or emphasize the point I am saying. This is a 52-year female with diabetes and heart failure. You can see that she's in heart failure. Inferior vena cava and hepatic veins are dilated. Inferior vena cava is not collapsing. And she has an ejection fraction, which is about 55%, right atrium and left atrium dilated. The left atrial volume is only 32 ml per meter square. This criteria are not fulfilled. However, if you look at the upper transmitral flow, and you would say, yes, this is a restrictive flow, the filling pressure should be elevated. But look at the other way. Look at the E to E prime medial, it is 12. And if you look at the E to E prime lateral, it is 6.7. And the TR velocity is only 2.34 meters per second. So this lady who obviously in heart failure clinical with normal left ventricle ejection fraction has E to E prime, which is not suggestive of elevated filling pressures. Left atrial volume index not suggestive of increased filling pressure. TR velocity not suggestive of filling pressures. Individually E prime medial septum not suggestive of raised filling pressure, actually is in heart failure. However, there are other things which helped us in this patient. One, of course, which Dr. Thomas pointed out was pulmonary vein D wave more than the S wave. We knew, of course, this is a parameter which can be used and sometimes would be helpful in these tiebreakers. More important, of course, as Dr. Lisa Thomas mentioned, is the correlation between wedge pressure and left atrial strain. In our patient, the left atrial strain was 10.8, indicating significantly elevated left ventricle filling pressure. How do we know that despite an E to E prime of 6.7, TR velocity less than 2.8, we have elevated filling pressure? Well, This is, of course, the correlation between wedge and global left atrial reservoir strain, showing an excellent correlation. And our patient somewhere with the 10 global longitudinal strain of the left atrium should have a wedge pressure about 25. Did we find so? Well, there is another study also which has shown a somewhat better correlation than what Dr. Thomas pointed out. But we catheterized this lady. The wedge pressure was 28 millimeter, as you can see here, and left ventricular and diastolic pressure was 26 millimeter mercury. Markedly elevated filling pressures, while the E2 E prime lateral was only 6.7 and E2 E prime medial was 12, and TR velocity was just 2.3 meters per second. LA volume wasn't increased. Just to tell you that echo parameters sometimes may not be useful in predicting elevated filling pressures in HFpEF. Quickly giving you another example of 26-year female, same kind of story, ejection fraction norm, markedly elevated, markedly increased left atrium volume 62 ml per meter square. So now we know that this is, of course, heart failure. But the left atrial volume is supporting us. And of course, you can see the inferior vena cava not collapsing. Again, transmitral flow pattern, the top right corner shows you a restrictive pattern, and you know that the left atrial pressure markedly elevated. But if you look at the E prime or E to E prime ratio, medially 7.2, that would suggest that the LV filling pressure is not elevated. And the E2 prime lateral is 6. However, here, the interesting thing is global longitudinal strain of the left ventricle was minus 21. Even global longitudinal strain is not suggesting anything. However, the good thing is TR velocity was 3.2 meters, one parameter. So there are only two parameters here which suggest that the pressures could be elevated, left atrial volume and TR velocity. So again, we looked at actually the global the left atrial reservoir strain and found that that was significantly reduced. Let me wind up with showing you a third case, a 70 years female, typical HFpEF, of course, with the NT-proBNP for 2008 picogram. Of course, you know that the lady is in heart failure, the inferior vena cava was dilated, LV function normal, left atrium is enlarged, and of course, this patient has an ejection fraction, which is by 2D is 58%, by 4D is 53%, and the stroke volume 63 ml. But we now see the typical restrictive flow pattern. E2 prime medial is 22. The even lateral is increased 16. So the E2 prime here is giving us an idea that filling pressures are significantly elevated. Now, with this kind of data, we see that the left atrial strain, which is 14%, does correlate with the echo internal consistency there with regard to E2 prime and TR velocity. However, not with the left atrial volume, which is still 33 ml per meter square. Of course, as Shantanu pointed out, left ventricle global longitudinal strain cannot dichotomize elevated filling pressures, as shown by this work from Roberto Lang, and which was mentioned by both the previous speakers. So one has to say that at rest, resting E2 prime and wedge pressure relationship may be good in HFrEF, but certainly is reasonably poor in HFpEF patients, as shown by recent data from Sharif Nege and of course Barry Burlock's work. Dr. Thomas did mention about this fact that one could use in indeterminate dysfunction or indeterminate LV filling pressure the peak atrial longitudinal strain, and if it is less than 20%, patient has elevated left ventricular filling pressure and will fit in HFpEF, and if more than 20%, patient may need further invasive or stress diastology. There isn't any doubt that multiple studies have shown that the relationship between wedge pressure and left atrial reservoir strain remains good, but simultaneously it remains poor with E2 prime ratio. Showing you another patient, 54 male with hypertension after PCI of LAD, you can see markedly increased left atrial volume, left atrial strain, typical restrictive flow pattern, and left atrial reservoir strain of 10%. Now that fits everywhere. However, when you look at the E prime and E to E prime ratio, E to E prime lateral 9 and E to E prime of 10, you know that the E to E prime is playing truant, is not telling us the exact picture, while left atrial strain, left atrial volume, and transmittal flow are telling us the true story. So the accuracy of predicting LV filling pressures can be increased by considering LA reservoir strain beside 4 standard parameters. This is what has been emphasized. Question is, can we use E2E prime in stress diastology to predict raised LV filling pressures? As Dr. Shantanu was pointing out, the fact remains that the cost of increasing cardiac output in heart failure is by way of increasing pulmonary capillary wedge pressure. So if we can show that the pulmonary capillary wedge pressure goes quite abnormal during exercise, one can surmise that this patient elevated filling pressures and by other criteria HFpEF. And I did mention this work by Gregory Lewis suggesting the upper normal bounds of wedge pressure to cardiac output ratio less than 2 millimeter mercury per liter per minute in normal individuals, and the pulmonary mean pressure less than 3 millimeter per liter per minute. Barry Barlog in the initial study did show that the wedge pressure rises markedly with exercise, including the passive leg raise. You can see the rising. However, the green bar actually is showing you the patients who have non-cardiac dyspnea. There the wedge pressure does not rise. So obviously we know one thing, that patients with HFpEF do show a remarkable increase in wedge pressure on exercise, on passive leg raising. And his study of 10 patients in 2010 did mention that E2E prime septal on exercise of more than 15 versus wedge pressure more than 20 on exercise. If you use this kind of correlation, you can increase the sensitivity to 83% and specificity to 100%. The question is the sensitivity that much in practice, and is the specificity so good? And unfortunately, it so happens it is not so. I did show you this study of Barry Barlog suggesting that if you use all the echo criteria without the stress, then the sensitivity is 60%, specificity 75%. To this, you add E2E prime on exercise more than 14. Sensitivity does go up, but the specificity goes down remarkably to 71%. So it is true that you'll pick up many patients of HFpEF, but you'll also misdiagnose many people who are not having HFpEF as HFpEF. So the fact is E2 prime does increase on exercise as shown by Barry Barlog's work compared to rest. However, the relationship between E2 prime and wedge pressure continues to be modest, both at rest and during exercise, repetitively suggesting that E2E prime, when increase above 14, is suggestive. But if it does not increase, that does not mean that the patient does not have heart failure with preserved ejection fraction. Of course, the pulmonary pressure can do better with a better sensitivity and specificity. But this interest, I have to conclude with this very interesting work from Korea. And they had 181 patients of HFpEF, and the green bar lower down actually is E2E prime ratio. Now you have to look at this very, very carefully. And the upper three bars are left ventricular end diastolic pressure minimum, maximum, and the frequent left ventricular diastolic pressure. With exercise, passive leg raising and active leg raising, the left ventricular end diastolic pressure goes remarkably as high as 28.6 millimeter, starting from 18 millimeter. However, the E2E prime just does not budge. It remains same, 10. So it may be that you can get patients whose E2E prime will rise on passive leg raise or active leg raise. But this large study suggests that E2E prime during leg raising cannot be used to diagnose HFpEF or to estimate left ventricular filling pressure. So there is a lack of robust clinical evidence to support the use of E2E prime in response to physiological or pharmacological intervention to estimate LV filling pressure and LV diastolic dysfunction. So let me summarize. In patients with exertional dyspnea and normal left ventricular ejection fraction, ASC criteria of 3/4 can pick up about 75% cases of HFpEF with 25% false positive. If ASC criteria combined with left atrial peak reservoir strain, pickup rate will improve certainly, and the specificity will also increase. In a good number of patients, exercise invasive hemodynamics are needed to correctly diagnose HFpEF, and the criteria, of course, could be exercise wedge pressure of more than 25 to be more specific and of course, a little less sensitive. E2E prime alone at rest on exercise has poor sensitivity but high specificity. And pulmonary vein velocity might provide additional information in some cases. Thank you very much.
Thank you, Dr. Mohan, for an excellent talk. I think you covered the various aspects of echocardiographic assessment in heart failure with preserved ejection fraction. I think a couple of questions to you. One is regarding how these parameters could be used in prognostication. For example, we all know that we can't use too much of a beta blockade. You know, the heart rates can't be really lowered down, but sometimes even a small reduction in heart rate can lead on to changes in the parameters, how this would affect the parameters. That is number one. And secondly, also are there any other correlations? For example, look at the mitral E velocity and, the global longitudinal strain in addition. So whether combining all these parameters, would it make a difference? And also, you brought out a very elegant point, the pulmonary capillary wedge pressure divided by the cardiac output. So echocardiographically, could we be really looking into these two things? For example, looking at the pulmonary capillary wedge pressure and also looking at the output, the index, the aortic velocity, or things like that. Are there any correlations which could be really looked into? So something beyond the usual things. Did stress on the pulmonary venous flow as well. So how good are all these indices in these various scenarios?
So finally, the whole thing boils down to, can we, using echocardiography, better diagnose elevated filling pressures or better diagnose HFpEF? And these three talks have suggested three things. Number one is that multi-parametric echocardiographic approach suggested by the guidelines is the way to go forward. To this, you should add additional parameters like left atrial reservoir strain, maybe an IVRT, and maybe, of course, the exercise E2E prime, and besides, of course, pulmonary vein in some cases. That also would not take you to 100% diagnosis of HFpEF. Even if you include natriuretic peptide, remember Barry Burlock study had 18% people with normal NT-proBNP, and Sanjeev Shah's work has shown almost 25 to 30% patient with normal natriuretic peptide. So we do understand that each parameter on its own does not have strong correlation with elevated filling pressures. With regard to your first point, beta blockers, I'm not aware whether reducing heart rate by virtue of that, reducing filling pressure is meaningful in patients with HFpEF who are dependent on heart rate because of limited stroke volume. They probably may have less dyspnea, but will have more fatigue. That is my point. The second point you said about getting wedge pressure from echo. Well, as I said, if the E2E prime continues is more than 14 average or more than 15 on a septal, you can reasonably predict the filling pressure elevated. But is there a one-to-one correlation? That doesn't exist. Can I use the equation given by Sharif Nege, which Shantanu showed, that is equal to 1.24 into E2E prime ratio plus 1.9? I think is completely something which I would certainly not recommend. A lot of people use that thing, and I would say that that's not the way to go about. So I thought those were the questions I captured from your talk.
Thank you.
Dr. J.C. Mohan, are we searching for something which perhaps is not really there? Because when we talk of BNP as a marker of heart failure with preserved ejection fraction, we say the sensitivity is 70 to 80% at the most in the best of studies. And most studies say 70%, and then you're supposed to use the algorithm for diagnosing heart failure with preserved ejection fraction by echo. So what is this 30% of patients where the congestion is such that BNP does not even rise? It's not stretching the heart at all. Why is the patient short of breath? A very simple question, but I don't have an answer to this.
I don't know whether the question is that the diastolic stress is increased and still BNP doesn't rise. It may be impaired secretory capacity of the ventricular myocytes, because it is a disease with multiple comorbidities, and we know that natriuretic peptides are secreted by ventricular myocytes in response to diastolic wall stress. But despite diastolic wall stress, in case there is impaired secretory activity, natriuretic peptide may not be raised and be indicative of elevated filling pressure, although diastolic wall stress is high. But my point again is that we should try to use as many parameters as possible to make a diagnosis and not rely on a single parameter. And this multi-parametric approach of 4 by ASC now should include at least the left atrial reservoir strain and possibly some kind of stress diastology, although we need to sort out this issue of stress diastology to a much greater degree. And the reason is there are conflicting studies. When I look at the Korean study and I look at Barry Warlock's study, they are giving two completely different messages. I'll ask Dr. Thomas to comment on that aspect.
I think, as you've highlighted, it's an area where more work needs to be done. There was a study done from the Mayo Clinic by J.O., and he looked at patients who had normal resting E over E prime, which remained normal post-exercise, those who increased E over E prime, and those with elevated E over E prime at rest and exercise. And again showed that there was a correlation with left ventricular reservoir strain, demonstrating that reservoir strain was lower in the group that showed exercise-related changes. So I think we may be seeing, the important thing here is that we see a spectrum of patients, and the pathophysiology may vary when we look at the individual patient. We need to take in much more than just, one parameter or even a couple of echocardiographic parameters. The EACVI recommendation for HFpEF association suggests that we need to look at the clinical parameters, then we need to look at NT-proBNP and echo. And I think if we add all these things, because nowhere in these parameters is left ventricular mass measured. Nowhere in these parameters is blood pressure included. And each of these parameters will definitely have an impact. So it's sort of looking at the overall picture.
But Dr. Thomas, sorry, I'm disrupting you. The ESC criteria, the 2019 Pasquet and colleagues criteria, they do mention left ventricle mass more than a certain amount, 114 grams per square.
No, what I meant was in this multi-parametric assessment of left ventricular filling pressure, in that document, we've not taken, like we just say, if there's structural abnormality of the left ventricle, like reduced ejection fraction or increased mass, but haven't sort of added that on further. So sometimes we feel the more we do, in some ways, the less we know, because it creates and opens up more questions, which in some ways is exciting and provides us avenues to keep working.
Much more actually pertinent is that we can't rely too much on exercise E to E prime. Because if it is abnormal, it is helpful. But how often it is abnormal? Again, the abnormality probably would be in 50-60% patients. Could be 70%, but there will be a good number of people who have HFpEF, whose wedge pressure is increasing, but their E to E prime on exercise not increasing.
No, but
and we may need Korean work is typical of that.
Yeah, we may need to, in those instances, look at the TR velocity, and you may find that the TR velocity increases significantly.
So, and
it's not just, I think, not just the single E over E prime measure.
Absolutely. The only problem is that let's say there are 10 patients of HFpEF, getting good TR signal would be what, possible in 3 cases, 4 cases. So it is an excellent parameter. And of course, on catheterization, if you get PA pressure in such an individual, the sensitivity stress is high. But our difficulty is we don't catheterize all patients HFpEF, and also the fact that TR is not, and I'm sure that somebody will come up with a paper saying that you don't get TR, do a pulmonary exhalation time and below blah blah and below 80 milliseconds. Then this somebody will come up with this thing, because the problem with small studies is that you sometimes, especially small studies, single center, you tend to give a a message which could be misleading.
Lisa, what is your opinion about the passive leg raising, the recent paper on circulation? I mean, do you think it is helpful on bedside?
So I think it has been shown that it's effective to increase preload. And in fact, there's a few other papers where they've used more sophisticated ways to increase the venous return. So you can actually have mechanically increase the pressure. They have like a cuff or a stocking around the lower limb, which can be inflated, thereby increasing preload. So I think each of these things is just demonstrating that if you can physiologically change the milieu from what we see in the resting state, will this unmask the presence of abnormality?
But
and certainly it may be easier to do in sort of patients who can't exercise much to consider doing a passive leg raise rather than exercising these patients.
But it is such a heterogeneous syndrome that you can get very variable responses in different kind of patients. And so one shoe is not going to fit all. This passive leg raising, somehow the Koreans did not show the E2 prime changing at all with passive leg raising or active leg raising, although the left ventricular diastolic pressure is progressively increasing. Now comes the question, actually, even Oman's work here, you have a wedge pressure, you have a LV diastolic and diastolic pressure 29 and E2 prime is 10. On passive leg raising. It's tough to actually surmise how these things are happening.
Yeah, I think another major consideration is what is the normal value of E prime. We don't factor in age-related E over E prime. You showed very interesting cases, Dr. Mohan, but many of them were fairly young. And you wonder whether using the standard E over E prime or the standard E prime value may be in some ways underestimating what should be the normal E prime for someone who's that age. So a lot of times guidelines tend to look at the majority and they want to simplify it so that people can use it. But it's then that we start to find that one size doesn't fit all, and we have to factor in so many different sort of considerations before we can make a conclusion.
I think
Thank you, Dr. Lisa. Yeah,
with
wonderful.
those words of wisdom for Lisa, I think it's close to 1 a.m. So I think we need to close. Dr. Hari Krishnan, are you here? He was not well. So Hari, please conclude.
Yeah. Thank you, Dr. Lisa, for joining us and keeping you awake till 1 a.m. Sorry for that. And I thank all the other two speakers, Dr. Sandhanu for organizing the whole thing, and Dr. J.C. Mohan for that wonderful presentation. So without, already we are late, and thank you everyone. Good night. And next month we will come with another topic in our monthly seminar series. Thank you so much and good night.
Thank you.
Thank you.
Bye-bye. Good night.
Bye.